single, complaints of postcoital and intermittent bleeding, history of a chlamydial infection, cancer diagnosis is CA cervix. So here again, from the oncologist perspective, I would request Sampata madam to discuss about the CA cervix and the possible options, especially even in this case also.
Okay, she's 31 years single and having post-coital and intermittent bleeding. First thing, diagnosis of CA cervix.
CA cervix. Still, we have kept it open. Not, I have not mentioned stage and all because both the stages. Then we will discuss like early and the late stage.
So I hope it is proven by biopsy.
Yes, yes.
So first thing that I would like to look at is I would like to do a clinical examination. Definitely to look at the size of the lesion and an MRI of the pelvis to look at the size of the lesion, depth of stromal invasion, lymph nodal involvement, and if it is proven by lip biopsy or by conization, I would like to look at the margins, as well as I would request the pathologist to look at the LVSI, whether it is focal, whether it is present, whether it is focal, or whether it is an extensive LVSI. So if the lesion is less than 2 centimeter in size, no deep stromal invasion,
yes.
preferably no LVSI, though it is not an contraindication and not always it is possible, and lymph nodes are not negative, not enlarged on the MRI, then this patient can be a candidate for fertility sparing surgery.
Yes, yeah.
But I would definitely refer this patient first to the fertility specialist, because sometimes we might end up getting it not a candidate for fertility sparing surgery.
Yeah.
So the options of oocyte cryopreservation or embryo cryopreservation needs to be discussed with her irrespectively.
Yes, ma'am. So for even if suppose for example it's an early stage and we are doing either conization or trachelectomy, so generally how much time you would give to us, like in the early stage, or if it is a late and we have to directly go for say radiotherapy first, so how would be the time frame?
Early stage you can have a 4 weeks time.
Okay.
It doesn't progress so fast as this thing, so you can have a 4 weeks time in which you can stimulate and keep the.
Okay, so in the early stage if we are looking and she's going for the fertility sparing surgery, so we have 4 weeks time. So I would just like to ask Dr. Chaitra about this case, like what are the challenges because of the CA cervix? Of course the option would be she is 31 year and the single, so maybe we'll go for the oocyte cryopreservation, but what would be the challenges from our side? Can you would you like to mention about that?
Depending on what the oncologists also, inform us. The first thing when a patient comes to us for a fertility preservation, we would call up the team from the other side to understand exactly, because they are the patients who have been with the oncologist for a longer time. So we would want to know what is the prognosis for this patient. Yes. And how much time do we have? If we have quite a lot of time, maybe at least 15 days to a month, then we could think of doing an oocyte cryopreservation. Yes. And if it is a later stage of CA cervix, then probably doing a transvaginal oocyte retrieval may be a challenge.
Yes, correct.
But,
yeah.
But if it is later stage, again we'll have to go for an abdominal oocyte retrieval. Yes. With the understanding to the patient that the number of eggs got on the scan and what we actually have in the lab may be lesser, because transabdominal is a more challenging approach for the egg collection.
Yes, yes.
So that is something that we'll have to tell her.
Yes.
So again, it depends on the team approach and how much time the onco team gives to us. Yes. Depending on that, I would want to counsel this patient.
Yes, as madam said, we had 4 weeks time, so stimulation would be better, but then as you said rightly, there will be challenge in doing a transvaginal pickup. So here again comes the counseling part about it, like these are the challenges, number of the eggs we might get, they might be little limited. And of course further I would like to ask Dr. Anjali, like suppose this patient after treatment, she has had a trachelectomy, so we would face certain challenges in her pregnancy. So can you put some insights on that?
Yeah, so basically if this patient survives and she conceives, and she has undergone a trachelectomy, then definitely she will be at risk of, second trimester abortion, because the cervix will be short and it might just give away. So we have to counsel them appropriately that it is going to be a high risk pregnancy. She has to take, extra progesterone support, and we can also do a cervical encirclage in such patients. But again, it will be technically difficult because we will be having very short cervical length for the procedure to happen. So we might have to do it transabdominally. We might have to do a Shirodkars and such things. And one more thing I would like to say, that if this patient is for chemo radiation, then instead of doing a oocyte cryopreservation, we can go for an ovarian tissue transposition, or the shielding of the gonads. Wherein we can just remove the ovaries from the field of radiotherapy, and we can just fix it to either to the anterior abdominal wall or to the paracolic gutters. With the help of a simple non-absorbable suture, which can be cut once the patient, completes her cycles of chemotherapy and radiotherapy, so that she can even have a natural pregnancy. She might not have to go for a IVF procedure.
Yes, that is very true.
The other treatment options in this particular case.
Can I make a comment here?
Yes, ma'am, please.
Two things. Once we do a ovarian transposition, there are 30% chances that the ovaries might fail. Because of the blood supply, we hang it up. Sometimes it can get twisted. Second thing, there is a scattered radiation that occurs.
Correct.
So a patient has to understand. Third thing, your retrievals becomes difficult with this thing. Once they are in the paracolic gutter. Thirdly, when you irradiate that uterus, the uterus, I don't think so with so much high dose will be able to bear on the pregnancy. So
that is very
with
important.
her is not possible. It will be a surrogate pregnancy.
Correct. So especially if the radiation is our first option, in such a situations, we need to tell her about the more important would be the uterine damage, because it will be a thin endometrium, fibrosis, it may not respond later, and even if it might be a miscarriage, either a first trimester, second trimester. So definitely the need for the gestational carrier, that is surrogacy, is very important in such a situations. Definitely with the early stages we can go for while taking all the precautions. That is true. Yes. So we will move on to the next case.
Can I ask a question?
Yes, ma'am.
Like the question that was asked for testicular tissue cryopreservation.
Yes.
Do we have centers in India where ovarian tissue cryopreservation is done, and do we have a center in Mumbai where we do ovarian tissue cryopreservation?
So it is the same, ma'am. Basically, we still not have, we are not having the uniform guidelines. So as of now, we have got all the facilities where we can do all this, because in the routine patients of the, not a cancer patients, routine fertility patients, we do the testicular tissue preservations, and along with when it is the azoospermia, and we have got the good sperm retrieval, we freeze the sperm as well as the tissue. So those things are still in the experimental phase, though the ASRM has removed that experimental label from the ovarian tissue cryopreservation, but still in India we have to have the uniform guidelines for that, and that is very important that we should have those centers as a one unit. It has to be a one team, because again the transportation would be a problem. Immediately once the surgery is done, as soon as the surgery is ongoing, it has to be in the same building where it is immediately transported to the lab and other processing has been done. So the techniques, the medias and everything, it is available, but we have to work on these things. So
at present we don't have any facility of ovarian tissue cryopreservation in India.
Yeah, so we can't practically do it. So all the facilities are there, labs are there, everything, but the practicality is not there. So we have to work on those things. Basically, we can team up and have these all things can be sorted out, but yes, it requires a regularization. Yeah.